Good morning. Before we begin, I would like to respectfully acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Silks Okanagan Nation. I would also like to acknowledge that you are joining us today from many different places, near and far, and acknowledge the traditional owners and caretakers of those lands. Thank you for joining us today on World Mental Health Day. I am Jennifer Jacoby. I'm the director of the Institute for Healthy Living and Chronic Disease Prevention. And I'm very excited to welcome and to hear from our speakers today. Before I introduce them, I want to identify and speak to a few organizational aspects of the webinar. The first one is after the webinar, you'll receive a survey. Please take a few moments to share your thoughts and ideas on what and who you might like to hear from in future webinars. We do our best to reach the public's learned needs, and we value your opinion and your feedback. Also, closed captioning. The closed captioning box can be moved to anywhere you prefer on your screen or even by closing it. You can drag and drop it and place it where you would like, or to turn the closed captioning off, select the hide caption button on the menu bar. For questions today, please type them in to the comments for the speakers into the chat box. This can be done during the presentation, and at the end of the presentation, the questions and comments will be read and the speakers will address both questions and comments. And we look forward to hearing from you, the audience. Now, on behalf of the Institute for Healthy Living and Chronic Disease Prevention at UBC Okanagan, I am really pleased and excited to introduce today's presentation. Mental Health Conversations with Older Adults in Community Care, a national research study. And to present these findings today, we have Dr. Nelly Oelke, who's an associate professor in the School of Nursing in the Faculty of Health and Social Development here at the University of British Columbia, Okanagan. Also joining her is Adriane, who's the research assistant for this work. She's also in the School of Nursing at the Faculty of Health and Social Development here at UBC Okanagan. So with that, welcome Nelly and Adriane, and I'm going to hand it over to you.
Great. Thank you so much, Jen, for that great introduction. And we are, Adriane and I are really looking forward to presenting the information on the study, some of the results as we progress through the study, and very open to your questions as well. Next slide, Adriane. So I know that Jen has done a land acknowledgement, but I'd also like to acknowledge that this work has occurred on many First Nations and Métis lands in BC, Ontario, and Nova Scotia. These three provinces are involved in the study, and there is both an urban and a rural setting in each of the provinces. Next slide. So mental health conversations with older adults, why do we focus on that? Why is it important? So there are many missed opportunities to integrate mental health care into physical care. And so physical care becomes the first and foremost component of care for older adults in the community, whereas mental health then sort of is second place or even lower down than that. So there's dual stigmas that also impede health-seeking behaviors. So there's ageism as a stigma, as well as mental health. And in our aging populations, that can be even the mental health stigma bigger than in other age groups. We need to build capacity and develop evidence-informed initiatives to be able to integrate mental health care into our community health and social care in the community. So the goal of this project is to design and test an evidence-informed approach to starting mental health conversations between health and social care providers in the home, in home and community care settings with older adults and or their family caregivers. And so this, could be for people who work in home care, people who are companions. Those are or public health nurses, home care nurses, and others who provide care in the home. Next slide. So this is a multi-phase study. There are 3 phases to the study. We've just talked about the overall aim. So the first phase was focused on adapting and validating the mental health continuum model, which will show you the original one as well as the adapted one shortly. But the original mental health continuum model was developed for the military in Canada, and that's where it was largely used. The second phase was to co-design mental health conversation processes and follow-up actions in community care settings based on the adapted mental health continuum for aging Canadians. And then third, we are looking at evaluating the implementation of the co-designed and evidence-informed mental health conversations initiative at the point of care to assess its feasibility as well as outcomes. We also are supported by a Pan-Canadian Experts by Experience working group that advises on all components of the study, particularly on project direction and supporting diverse community engagement and development of the study materials as well as knowledge translation. And just want to highlight that we have a few QR codes within our presentation that focus on papers, or also you can download a copy where you can better see the mental health continuum as well. Next slide, thanks. So in phase 1, we're looking at then adapting the mental health continuum model. And so we did online workshops. And so there were 4 3-hour workshops that were completed with 59 participants. Participants were included older adults, caregivers that provided care for older adults, health and social care providers, and those that provided mixed perspectives. We all don't provide a single perspective oftentimes, but we provide multiple perspectives. We then, after that, adapted the mental health continuum, and then I went to an online survey, and we collected data for 5 weeks in early 2023. We had over 1,000 respondents, and those included, again, older adults, caregivers, and health and social care providers. And this was done nationally. We did have a good uptake in BC, so just so you know that BC voices were represented. Next slide. So here we have the 2 mental health continuum models. So the initial one that was used by the Department of Defense, National Defense in Canada, and then our adapted version, the mental health continuum for aging Canadians. And again, the QR code is here. But just to reference the old version, and then I have another slide to talk a bit more about the new version, but you'll see that the language may not be relevant to older adults, and there were a number of different things that needed to be changed. So next slide. So this then is a larger version of the new model. And so some of the things to take note is on the left-hand side, the thoughts and feelings and all of those descriptive components were adapted from the original model. And the language was changed so that it was a bit more inclusive would be the best way, and more understandable as well. So one of the big things that habits and coping strategies was previously labeled as addictions, substance use, that sort of thing, and so that has been changed quite significantly. We also then, across the top, the categories also changed, and instead of rather than sort of a stoplight approach, we have all good, take notice, find support, and seek care. And then lastly, the colors changed very significantly. The colors weren't resonating with folks on the green, yellow, orange, and red. They were also traumatic for some folks, and so those were changed to a single color that was much more, it had a more peaceful sort of component to it. And then the signs and symptoms in each of the categories have changed fairly significantly as well, mostly from a language perspective, but also to really encompass what it means for aging adults. Next slide.
I'll take over from here. Hi, I'm Adriane, and I apologize about that previous slide. There's a surprise text box in my PowerPoint, and I will pull that up again for you at the end so you can see everything clearly. So for phase 2 of this project, we wanted to co-design additional resources and processes based on the continuum to support home and community care providers to use the model and engage their clients in mental health conversations. We have been working with 15 different home and community care organizations across 3 provinces, as you see here in BC, Ontario, and Nova Scotia. The demographics of our sample of providers are reflective of the Canadian health workers as a female-dominated and aging workforce. We hosted 7 workshops in the 3 provinces, and in each of these, we engaged participants in making and actioning work by using activities to help them move beyond explicit surface level ideas or responses, but instead to help people tap into that creative and messy innate process that generates some really unique and innovative solutions. We did this in an iterative way by having participants in small groups first generate their best idea in activity 1, you can see there, for what the model could look like. You can also see on the right the worksheets that our participants were given to write down, draw. We gave them glue sticks, markers, anything they wanted to feel creative and really map out what they were envisioning. So we asked them for their best idea, and then in activity 2, we asked them to create a scene, create a script for using it, and then actually act that script out in what we called body storming. Other participants, while one group was body storming their idea and demonstrating the skit up front, the rest of the participants would write about how they felt about what they were watching. So then actually acting that script out and ultimately reflecting on the different skits and ideas. Then we came back in activity 4 in the large group and had a discussion about all of these ideas. So what was developed as a result of this work in phase 2 is called the Mental Health Conversations Initiative. The initiative has 5 components. And the first component is an implementation framework, which is a resource with information about different factors health and social care organizations should consider if they want to implement the Mental Health Conversations Initiative. The framework will have key messages to support change leadership or talking about the initiative with other leaders within the organization, For example, why do mental health conversations matter to value-based care? And how can this support post-COVID resiliency and advance workforce stabilization efforts? There will also be information about what needs to be in the place at the organizational level and point of care to be able to implement the initiative. This also includes training for care providers, which we have incorporated as a distinct part of the initiative. We will also include messages in this training from the Phase 2 workshops, data that shows the values and benefits that providers see in the initiative. The next element of the initiative we will develop based on Phase 2 feedback as well, and is a conversation guide that can support providers to prepare for and conduct mental health conversations. The idea is that this resource provides guidance, but also recognizes and leverages care providers' existing skills and their knowledge to support them to have these conversations. We plan on making a long and a short version of this, with the short form acting more of a quick reference that providers could use before going in to see their clients. The conversations guides will contain a decision tree with information about how to use the guide, principles that providers should keep in mind during mental health conversations, for example, having empathy and creating a safe space. There will then be information about each step of the mental health conversation process, such as preparing to have a conversation and thinking about when is a good time or a bad time to have a conversation. There will be prompts that can be used to start the conversations and tips on how to navigate. There will also be actions to take post-conversation. For example, whether you ask a client to do something before your next visit, or if the provider should speak to their supervisor about their client's mental health support needs. The last component, aside from the conversations themselves, is a mental health conversations toolkit. The toolkit will contain resources for providers, older adults, and caregivers to support the conversations. The workshops provided many ideas regarding the format and functions of these resources, and some resources are planned to stay with the clients in their homes, while others may travel with the care providers. To find the best mix of toolkit formats that also meet the functional needs, we are currently working with a design company to develop concrete prototypes of these resources that we will use in the next phase of the study. I apologize for this graphic. It's hard to put as many ideas as we have so far on one page, but it begins with this library, which represents about 30 initial prototype ideas that have been derived from the data gathered during Phase 2. The resources fall into 3 general categories: tracking and self-reflection tools, conversation support tools, and information and educational tools. These ideas will continue to be refined and narrowed down between our working group and the participants from Phase 2 to ensure that they provide the intended impact and are useful for the people who will ultimately use them. Nelly, I'll pass it back to you if you don't mind.
Right. I think I just want to emphasize, so sort of what are the next steps for Phase 3? And we have been working with organizational partner organizations in each of both a rural setting and in a urban setting, and they have all agreed to continue to work with us and into the Phase 3 of the project as well. So just for your information, we're working with Penticton as our urban center with One Sky, and then for our rural work, we are working with organizations in Princeton, Karameas, and Osoyoos. And so that is a group that we're working together with to be able to carry out the Phase 3 of the project. And so Phase 3 will include we're developing the toolkit, so it will include a variety of different tools, and anything from fridge magnets to calendars, where people can document or put stickers on or that sort of thing, as well as different formats of the mental health continuum, and other different ideas. So that will be available for phase 3. But also we will be recruiting then both caregivers and health and social care providers. And we will be recruiting then, they will be recruiting patients from their group. And we're hoping that in each of the areas that we'll have about 15 interactions where we are actually trialing out the Mental Health Conversations Initiative. And so that's sort of the next steps. And so both recruitment, development of the toolkit, recruitment, and then from there we'll be doing training with the health and social care providers, and then looking at recruitment of patients or clients as well, and then doing an evaluation of that implementation, and looking at both quantitative and qualitative data collection through surveys and or interviews as well with all of the different parties. So we're hoping that in the long run that we can actually use this Mental Health Conversations Initiative and scale that up to other communities, to other areas across Canada, and work via that, to create a good option for actually providing mental health care and support for older adults that live in communities but receive care. There has also been some concern that some of the care or the providers might be entering into situations that are beyond their scope. And so we have been very clear that that this should not be the case, and they should be having conversations with their supervisors so that the person can get appropriate care. The problem is if we don't start conversations, these people will not get mental health support. And so it is important to start at that point. And so we're looking at creating a shared understanding of mental health, and then building capacity for providing mental health support to aging Canadians. Next slide. I know our presentation has been shorter, but I think that leaves us more time for questions. And so happy to connect with you, both Adriane and myself. Please feel free to contact us. The lead of the research is Justine Giosa, and she is with University of Waterloo and the SE Research Center that does a lot of focus on care for older adults. And again, the research protocol QR code is there, as well as the QR code for the mental health continuum model. Thank you.
Thank you, Nelly and Adriane. All right. Well, that was really insightful. I heard during the presentation, Adriane, you were speaking about going back to that one slide. Did you want to do that and start from that perspective?
Sure. What I might do is stop sharing this and share a different screen that has the image.
Right.
There we go. That's better.
Okay, so since we're back to the screen, maybe if you wanted to just give us, as Nelly spoke to the history of the changes in the colors and how you kind of landed here, from your perspective across this continuum, what do you think is most insightful or most helpful for older adults?
I found that I did a lot of the data analysis, the responses from the participants in both the survey and the workshops. And I felt that there was a lot of the same general feelings of the color was a lot more appealing. It doesn't have that kind of striking, alarming feeling if you're moving into the red, and that it really supports the idea of mental health as a continuum, that you can have poor mental health, but still be okay. And you can have great mental health, but still be dealing with things. So it's nice to have that sort of acceptance across the board. If, you're feeling today that you're emotionally well, but you haven't been sleeping well lately. And so that can start to affect your mental health over the continuum. And through this initiative and developing the tools that we want to use, will help you keep track of your experience in mental health over time. And then that might also make it easier for a lot of people to recognize when they might be slipping into behavioral changes that aren't good for their mental health. So I really feel like the changes that were made in that way, the coloring, the little helpful arrow, and supporting information at the top there is great. And then expanding some more on all of the issues that happen in older adults' lives that just weren't brought into the forefront as much with the original continuum. And we have had the comment that it is a little wordy, um, and we understand that it may appear quite overwhelming at first. But hopefully the blue helps you go into it calmly and realize that when we tried to say, okay, maybe we can summarize this or we can remove this, we couldn't. Everything you see here we felt was important, and that's why it stayed in the continuum.
And I think that one of the other things to really emphasize is that it it speaks to relevant things, as Adriane talked about, for older adults. One of the habits and coping strategies just really was quite different than the older, original version, because it included alcohol, medications, drugs, tobacco, food, as opposed to only oftentimes including alcohol and drugs. And because things are, again, very different for different folks, but so it was more inclusive. So that's one of the things as well. We tried to keep the language at a lower level of language, but that was challenging as well. But we did work on that as best as we could. So thank you.
I'm also curious, you identified the different sites with rural and urban. Are there things that we should be aware as individuals, especially older adults, live and move between different communities when it comes to mental health?
I think overall, it's pretty clear that people who live in rural communities have less resources both for physical care and for sure for mental health. And so, and who are the health and social care providers in rural communities is extremely broad. And so that was, I think, pretty clear in our phase 2 workshops, that the people who are around the table were included all sorts of folks. And even in Penticton, you know, we had a different shift, but it's a small urban community, and is also, you know, different than you might find in Toronto, for instance, or those sorts of things. So we actually, it's kind of nice. We have medium urban and, or, you know, small, medium urban, and also large urban from Ontario as well. But rural always is, I think one needs to really acknowledge that context is different. And, you know, transportation is really challenging for older adults particularly, but just in general. And then given weather patterns, you know, road situations, et cetera, that can also make things very, very different, where an older adult may be quite isolated for a period of time in a winter storm situation or whatever.
Thank you. I'm also going to remind audience participants to include your questions or comments in the chat box. That'd be very helpful for Nelly and Adriane to address. We do have a question that I'm going to read out now, and Nelly or Adriane, you can choose how or who you would like to answer. It actually refers to a little bit of methodology with respect to, could the survey questions be shared once they've been completed?
I think that, you know, once we've used the survey, piloted it, et cetera, and present the results, I can't imagine that we couldn't share the questions of the survey as well. It would only make sense to share that to actually make sense of the results. So, you know, I take down my email address, and happy to share, you know, what we can when we have that. The survey is under development, but it has not been finalized yet.
Thank you, and thank you. Place your email. See, it's basically for those that don't know first its name at ubc.ca. Put your in the chat box for participants. We also have a question with respect to, and I'll read it out. You've just listed off quite a few blocks or issues that we have amongst communities, as being with role for older adults. So I think it's a very nice way to think for identifying challenges that exist between groups.
Yeah, you're breaking up a bit, Jen. Not sure if you need to turn your camera off or whatever, but yes, thank you, Patty, for the comment. I just to give you a little bit more background on myself, I am a scientific director for the Rural Coordination Centre of BC, as well as working for UBC Okanagan in the School of Nursing. And so that really it's so rural is very close and near and dear to my heart, and I work with a lot of rural communities across the province.
Stella identifies that the blue page really is a concise, practical, hands-on guide that hits the issues right on the nail. Great work, team.
Thank you. So it hasn't been published yet, the actual mental health continuum. You know, we are sharing it with folks. You know, we don't want you to use it broadly at this point in time, but it is there as a reference for you.
With respect to that, Nelly, what's the applicability and how can it be used in community care at this point? And then once it's published and going forward, how can it be used? Is there a difference, or is there an approach to actually use in community care?
Well, that's really what we're trying to find out and figure out in phase 3, is to understand how it can best be used in community care, for by our health and social care providers, to work with older adults and their caregivers as well. And so, at this point in time, I think it's a reference. Once we move through phase 3, I think we'll be, entering into phase 3 in January, and moving through that probably for 6 months to do it. And then, analysis of the data. And then I think we'll be able to provide better information around, so how can the continuum best be used, but also what of the toolkit items and how are they best used, and how did health and social care providers adapt how to implement this, and what worked best for clients and for their caregivers as well. So I think it's a stay tuned, and maybe we should do another presentation, the end sometime later next year, to really talk about sort of what we found.
That's great. And if individuals want more information or to learn how participation might occur in phase 3, I would suspect they could just email you or Adriane.
Yes, please. Yeah.
All right. That's perfect. Now, Paul has a comment here, and I think what he's getting at is the relationship between mental health, physical health, and different care providers, if I've summarized that correctly. So I'm just going to read for the audience and for yourself. So the study seems to be focused on the indicators of mental health needs to assist providers on understanding and actions. There seems to be a focus of how is mental health conditions which are not connected to physical aging aspects, which are the result of poor general health care. So, for example, ongoing pain is untreated is a provider problem, but creates mental health problems. So currently the study identifies indicators, but it is not connected to other healthcare providers' lack of availability. So could you maybe speak to the connection between different healthcare providers, between mental health and physical health?
Yeah, that's a really good comment, Paul. Thanks for that. In all situations, mental health and physical health are operate in big silos for the most part. And that's a problem. We need to integrate mental health into the physical health. And just to highlight from our nursing program, we made some changes about 5 years ago that mental health was integrated into all years of the program for our nursing undergraduate students, as opposed to just being a specialty. And so we're looking at community, particularly in the community, although it happens in, if an older adult is admitted for a physical health issue, people don't ask about their mental health and how they are doing. And that's a problem. And so we have that same situation in community settings as well. And it is about providers not talking to each other, but it's also about providers not having the skills and the knowledge about mental health, and thinking about that as much as they are thinking about the physical health. And then I think it's also an issue around capacity. And so you have a care provider that goes into the home for home care support, and they have X number of minutes to provide a bath. And so then they don't focus on the mental health piece, but let's sort of orientate that and think about how they can actually provide that bath, but talk to the patient, the older adult, about how are they feeling mentally? How are, what's, do they have support systems? Do they have somebody visiting, or are they lonely? And then thinking about, so where do you go from there, and being able to have more conversations, or do they need actual support for their mental health? Adriane, did you want to add anything to that?
I was just thinking about the fact that throughout these surveys and the workshops and speaking with care providers themselves, a lot of the time they're getting into these conversations with unexpectedly. So the older adult themselves starts bringing up things about their mental health. They're not feeling too great, or over time the care provider sees that there is a change, a decline in their mental well-being, and so they were really excited to see that there was something that they could provide to their older adult clients in the way of, hey, so I just learned about this great tool. We got trained on using this mental health continuum. Did you want to look at it with me to see if we can talk about maybe what things are going on that we can help you with? And it really gave them a platform to have the conversation, even without even really knowing how to use it yet. So the guidance that we'll be providing will be based on their feedback and their capacity within their organization as well.
Yeah, from the phase 2, people were saying, so when can we use this? When can we use this? That's, their excitement around something, a tool like this.
Really speaks to the need for certain.
Yeah.
And Karen's also asking in the chat box with respect to kind of needs and next steps. I'm just curious, Nelly, and happy to discuss later. How can PACCs across rural areas help out with the implementation and explore what works best for clients, patients, and healthcare workers?
Okay. Yes. So this is a patient based organization or community members, and I think the voice of clients, the voice of community members and patients is really really important in this work. And so there were opportunities earlier. We probably have less opportunities at this point in time, but I would suggest from a knowledge translation perspective that this could be very important, Karen, in being able to share the information, but also to better understand. So how do we implement and what works best from our perspective, but also understanding what might also work best from others in your organization as well.
Thank you. Tina also comments, thank you, Nelly, for a meaningful project. My question for you, what were the biggest challenges when you contacted your potential participants?
So we haven't talked, well, we have engaged with a lot of older adults, caregivers. It was easier to engage with caregivers than older adults. And that's not surprising. Older adults, we might not have connected with them, or they aren't able to actually participate in some of these pieces. Providers and health and social care providers was also, a group that we did connect with, absolutely. And we had a good connection, but in phase 1, but less so. But they became more connected in the workshops that we did face-to-face in phase 2. I think I alluded to the fact about concerns about moving out of scope for care providers. And that it definitely was a challenge that we experienced. And so trying to be clear that this is not what we were trying to do, that definitely we did not want people to go out of scope, and that they needed to be able to, if someone needed help, that needed to move on to a different person and be acknowledged and shared with their supervisor. But also on the flip side, acknowledging that if we don't start mental health conversations, this likely will not happen for older adults.
Really good point. It's the starting conversations and trying to engage in really sensitive, important topic for older adults. It's growing. Adriane, did you have anything at this point you would like to add?
Maybe just for that last question, in my mind, I was thinking more of the challenge of time that the care providers, that was my most challenging moments, was getting everyone in the same room at the same time, which seemed like wishful thinking at one point, but it turned out really well to have all of these people together and sharing all of their ideas in one room, and really using the actual physical energy of each other to get excited about it. But time is hard for our care providers, and that is also an aspect of this project, is respecting the fact that they may only have half an hour with a client, and so that a tool they can use that's quick and easy to understand for both is really important. And yeah, they seem to appreciate us understanding they're all stretched, and that speaks to also the resources that need to work together, especially in rural communities these days, where one person might have 4 different hats that they provide resources to people with. So that was also an interesting learning experience.
Really beautiful. That session itself must have been really enlightening, but also really important for the individuals who participated to be in a space where there were a lot of people facing similar challenges and dealing with various different issues that are so complex when it comes to mental health information. So you've identified time, and I'm going to acknowledge that we're coming to the end of our webinar today. And I want to thank you both very much for your contributions, for the work that you're doing, and for sharing that work with us today, Adriane. On behalf of the Institute of Healthy Living and thank you to everyone who joined us today, as well as the two of you. And just a reminder, you will be getting a survey, and please let us know your thoughts on what you, both as the public, as well as patient partners, thank you very much for identifying that in the chat box, might like to hear and see in future webinars. With that being said, it's World Mental Health Day, and I wish all of you a very wonderful day. Thank you for joining us today. Bye now.
Thank you, Jen. Thank you, everyone.